Hello, everybody. My name is Dr. Jordan Tate. I work at Southern Pain and Spine. I'm an interventional pain specialist. Today, we're going to be talking about new treatments for non-surgical low back pain and painful diabetic neuropathy. This seminar is brought to you by Nevro, and their product is high-frequency stimulation, also called HFX. We're going to dive right in. So first, in order to really set the stage, we have to make sure we're speaking the same language. What we're talking about here is pain. Chronic pain, acute pain, neuropathic pain. You may have heard some of these words before. We want to make sure that everybody understands what we're talking about. So what is pain? Well, pain is the way that the brain interprets information about a particular sensation that the body is experiencing. Our body is filled with electrical highway, that's our nervous system, allowing information to come from the brain out to the real world, and then from the real world back out up to the brain. It's the way that we can sense whether we're wearing a sock or a shoe. It's the way we can sense if our hand has been put on a hot stove. All of that information goes through the spinal column and the spinal cord and then gets it to the brain for processing. Some of these sensations will be labeled as pain. Pain can then differ enormously among individuals because some people have more sensitivity in their nervous system. Some people will have hypersensitized nervous systems that have been ramped up due to history of trauma and experience with a lot of different kinds of pain. And some people will have increased pain because their nerves themselves are actually damaged and carrying the wrong signal. There's also brain pathology that can heighten pain sensations, such as strokes and history of brain diseases and tumors. So in that way, brain can really differ enormously across individuals. So some patients who will have identical injuries or identical illnesses may have completely different experience when it comes to pain. In addition, once pain has been in your body for a while, it really can start to affect not only your physical components, but also your mental and emotional components as well. And if you start to disengage from social activities and become more withdrawn, more depressed, highly anxious, that can really ramp up the pain experience also. So a lot of these things need to be taken into consideration when we're thinking about what is pain. When pain has been in your body longer than it should, that's what we consider chronic pain. So for an example, if you twist your ankle or sprain your ankle, we would expect that within 6 weeks, that pain and inflammation and injury would be better and healed. And ultimately, the pain would dissipate. If the pain persists, we call this chronic pain. And the same can be true with a spine surgery, for example. If you have a spinal fusion, we usually anticipate that it's normal to have some pain in that area for the first 6 to 12 months. If it continues past that time, we consider this chronic pain. So chronic pain may start with an injury or an infection or an ongoing ailment, but it can continue outside of that realm of healing time. And that's usually because there is a change in the nervous system itself, something we call imprinting. It's like if you were to knock on a door for a year, eventually you stop knocking, that door has a dent. So that's the same thing that happens in our nervous system. The nerves will continue to carry that chronic pain signal, even though the healing process has already occurred. So this is an example of a pain cycle. It's a little figure here, and he's had an ankle sprain, injury or surgery, inflammation of the ankle. And as you see, as that pain continues for a long time, it can hypersensitize both the nerves and the spinal cord, and then eventually the brain. That can affect the cognitive processes, causing depression and anxiety. And that can actually change the way the brain signals and the way that the brain processes chronic pain and other sensory input. So some patients will become hypersensitive to pain and other stimulation, such that a light touch can be perceived as a painful feeling. So if you were to put a feather on your arm, it should feel like a feather. But if you've had chronic pain in that area or nerve damage, sometimes a feather on the arm for some patients can actually feel like hot burning fire. Ultimately, this can lead to avoidance and disability, so not engaging in normal activities, walking with different gait patterns, or sleeping in awkward positions, maybe transitioning to a recliner and no longer sleeping flat, And all of these things can really change the mechanics of your body and the muscle conditioning of your body, leading to chronic muscle spasms, deconditioning, weakness, which can often lead to things like falls or easily injured during sports activities. And then you can really kind of repeat that cycle of re-injuring yourself. So chronic pain in the US is in epidemic proportions. There's about 8% of the adult population that suffers from chronic, daily, around-the-clock neuropathic pain. There's about 80% of patients who've had a severe episode of low back pain in their lifetime, and about 20% of those patients will end up having some chronic, intermittent, or disruptive chronic low back pain. And as we can see, a majority of these patients who are dealing with a lot of this daily round-the-clock pain are mostly low back pain patients, but followed by neck pain, chronic headaches and migraines, various joint pains and osteoarthritis, and peripheral neuropathy. If you combine the cost of chronic pain that is spent in this country, it approximates about $700 billion at this point. And that's actually more combined than the cost that we spend on cancer, heart disease, and diabetes. When we talk about diabetes, we know it's also of epidemic proportions, especially in the US. Type 2 diabetes is very much correlated with metabolic derangement and reduction in active lifestyle and obesity. So approximately 34.2 million people have diabetes in the US. That's about 1 in every 10 people. Of those patients, we know that at least 1 in 5 actually don't even know that they have diabetes. So diabetes can affect the nerves, and when it does, it can either cause pain or it can be painless. When it causes pain, we call that painful diabetic neuropathy, and that's an acronym here on the screen, PDN. So you'll hear me say that a couple of times, and what I'm referring to is painful diabetic neuropathy. So patients who have diabetes, who have developed neuropathy associated with their diabetes, and in fact that neuropathy has become painful. So patients who have peripheral and painful diabetic neuropathy is about 20% of those patients with diabetes. And those patients represent about 5 million people in the US, and they will go on to try some conservative medical management, and that's what CMM is on the screen. Conservative medical management for painful diabetic neuropathy, of course, includes improving glucose control, but also using things for the pain, such as neuropathic pain medications like gabapentin, pregabalin or Lyrica, duloxetine or Cymbalta, amitriptyline or Elavil, or using topical compounds such as lidocaine or clonidine, capsaicin. These are all things that may have been tried or should be tried to conservatively reduce the pain associated with painful diabetic neuropathy. About 45% of patients who try those treatments will be refractory, meaning it has not helped them. They've tried them all, and the doctors are saying, well, we're kind of out of options at this point. You're going to have to learn to live with your painful diabetic neuropathy. And that represents about 2.3 million patients in the US. This is a list of some of those conventional medical management treatments. Also on the screen does include pain medications such as tramadol or oxycodone. Technically, these should be last line treatments for neuropathic pain. They don't have a lot of great evidence to support the use of opiate medications for painful diabetic neuropathy, but we do know that some patients report good functional improvement with these medications. So in the event that you find yourself having refractory chronic low back pain, either before or after a surgical intervention, or painful diabetic neuropathy, you may be a candidate for spinal cord stimulation. A lot of people want to know, is this a new treatment? If I undergo spinal cord stimulation, would I be some sort of guinea pig? And the answer is no, it's absolutely not true. It's been around since 1967. So we've been using spinal cord stimulation in some capacity for the past 50 years. And currently, about 34,000 patients undergo spinal cord stimulation procedures each year worldwide. The spinal cord system is pretty standard across a lot of different companies, but high frequency stimulation has some differentiating capabilities that we'll talk about. A basic spinal cord system consists of wires that we call leads. They're about the size of spaghetti noodles and they're flexible. At the end of the wires, they have contacts or ability to make electrical stimulation input into the spinal canal. And then they are attached to a small pacemaker-like device that is the battery that helps to run and control the power to the leads and the contacts, as well as some of the computer system that just determines at what rate and how often the stimulation will be delivered to the spinal canal. Prior to implanting this procedure, there's a trial. So you get to put it in temporarily and test run it at home to see if it works for your pain. So this is really unlike anything else that we have in medicine. You don't get to test run a pacemaker or a lumbar spinal fusion. You kind of just go for it. But in this case, there is an opportunity to test drive it, and you need to, quote, pass that trial phase. It needs to be effective for you in that first week at reducing your pain and allowing you improved function prior to moving on to having it fully implanted. When the trial occurs and also during the implant, the leads or wires are placed into the epidural space, very similar to when a woman is undergoing labor and delivery and has an epidural catheter placed. We will use the same technique to put these wires in place, but instead of delivering an anesthetic medication that makes you numb so that you can have a baby, in this case, we're introducing electrical activity, very similar to what you may have experienced with a TENS unit. It's a similar low dose, subtle electrical signal. So unlike a TENS unit, it's much more effective because you're not just placing it on the skin, you're actually going to the source where the nerves live. And in fact, it's really more like a pacemaker. So when somebody has an arrhythmia in their heart, their nerves are firing erratically and carrying the wrong signal, causing the heart to contract incorrectly. And similar to that, the spinal cord stimulator is readjusting the correct nerve signal so that a person with chronic pain who is carrying the wrong nerve signals in their body, causing the wrong outcome, we can override that by putting in the correct signals. And that's really what a spinal cord stimulator is built to do. Ultimately disrupting the pain signals to the brain and reducing the chronic pain. So there's a traditional approach which inputs a tingling sensation that helps to cover up the chronic pain signals, or there's a high frequency approach. And Nevro is the only company that is able to deliver this high frequency. It's a proprietary waveform that they have developed. And so no other company is able to give high frequency stimulation where you don't feel the tingling and can disrupt the pain without creating any new sensation for you. So as we mentioned, spinal cord stimulation has been around for a long time. It's been well established. We know that it helps to treat chronic trunk and limb pain. It was approved in 1989. And over the past 30 years, from 1989 to 2015, there really wasn't a lot of improvement. So if you know somebody who had spinal cord stimulation during that time, you can liken that to a patient or a friend who has an old flip phone. And since 2015, when high frequency stimulation came out, we now have the smartphone version of spinal cord stimulation. So there's been technological advances over the past 7 years, because I'm giving this talk now in 2023, so that would actually be 8 years, so that we have more technological advances. So that historically, spinal cord stimulation was about 50% effective. Now we quote that it's about 80% effective at reducing patients' chronic pain located in their trunk and limbs. This is a little bit about high frequency stimulation and Nevro. They've treated over 100,000 patients since 2015. Their therapy is not addictive. It does not cloud your thoughts or cause drowsiness or constipation like pain medications do. High frequency is offered at 10,000 hertz, and they also are able to do the traditional stimulation as well. So if in your case you were implanted with a high frequency device and the high frequency stimulation did not ultimately capture all of your pain, or you were to develop a new pain, you have the variability and the versatility to drop down to different stimulations or have different programs that treat various pain in your body. And ultimately, you're able to sleep and drive with this therapy on because it does not create tingles that can be disruptive to you. When we put the implant in, it is a battery and it is needing to be charged on a regular basis. The power settings of your battery will dictate how often you would need to charge. So for some patients, they do need to charge every day, usually 30 minutes or so. But other patients, if they are using their device less or at lower power settings, can actually get down to once a week or even as low as once a month on their charging. But ultimately, it is a lithium ion battery that is rechargeable and will eventually potentially wear out. And so we know that it's going to last at least 10 years, but after that, you may have to replace it. Here's a little video about how all of this works, and hopefully you can hear it. It'll last about a minute and 20 seconds.
A breakthrough treatment for chronic pain is here. It's HFX, a spinal cord stimulator, or SCS treatment option. HFX incorporates the most advanced SCS available, offering the widest range of frequencies and waveforms available to individualize your relief. It's FDA approved and is the only SCS system demonstrated to provide more people with significant relief from back pain, leg pain, and pain caused by diabetic neuropathy in clinical studies. Even people who have tried surgery and medications in the past may be good candidates for HFX. In fact, 8 out of 10 people who used HFX for severe chronic pain experienced a significant reduction in their pain, allowing most people to return to everyday activities and get back to what they enjoy. With patients suffering from chronic pain, abnormal pain signals are sent through the spinal cord to the brain. The HFX solution calms the nerves that carry these signals to provide lasting pain relief. In a simple procedure, thin, insulated wires are placed in the back near the spinal cord and connected to a small, implanted, rechargeable device. The device sends mild electrical pulses to the spinal cord to calm the nerves and reduce chronic pain. The procedure involves a relatively quick and minimally invasive outpatient procedure, which means you will likely go home the same day. You can use HFX 24 hours a day, including when you drive or sleep. Before committing to the procedure, you'll complete a 1-week trial where you and your doctor will assess its effectiveness in managing your pain. During the trial, the 2 wires are inserted in the back near the spinal cord and attached to an external battery. 9 out of 10 people who try the HFX solution stay with it. Ask your doctor if the HFX solution is right for you.
All right. So we mentioned that there's a temporary trial. The trial is typically performed in an outpatient setting in the doctor's office or ambulatory surgical center. Sometimes can be performed in a hospital setting. Generally, the patient is awake during the procedure but may receive some IV sedation. There is very rare circumstances where this would ever be performed under general anesthesia. The patient is laid on their belly under the X-ray, and we clean up and numb up the back. And then 2 wires are going to be placed through epidural needles under the skin and into the epidural space in the back part of the spinal column. The wires are then connected to a trial stimulator device that can be affixed to your skin, or maybe worn on a belt that delivers stimulation to the leads. The system is then turned on and activated in the post-operative setting. And the intention is for you to go home and test drive the system and see how it works for your pain. A typical trial lasts between 3 and 14 days, and on average about 7 days. If you feel like the trial system is working well for you, then you would be a good candidate for the implant. So in order to get this implanted, it is a small, minimally invasive surgical procedure that does involve creating 2 incisions, one incision over where the wires are inserted and one over where the battery is inserted. And you will have ability to determine where you want that battery placed. Generally, it will be placed around the waistband area, in the upper gluteal area, or in the love handle area. The patient also may be a candidate for a placement of what's called a paddle lead, in which case a surgeon will typically place that in a hospital under general anesthesia. But most of the time, these patients are implanted in an outpatient setting and will go home the same day without the use of general anesthesia. So before we decide whether you want a trial, you need to know, do you think this is going to be something successful for you? Well, if you're somebody who has been suffering with chronic back pain or leg pain or diabetic neuropathy and has tried and failed multiple conservative treatments, such as anti-inflammatories, physical therapy, and injections, or maybe has even started to take chronic pain medications and opiates and neuropathic medications, and you're still not finding good relief with your chronic pain, then it's probably something that you would be a good candidate for. We know that overall, the patients who tried traditional stimulators were about 50% better. If they tried high frequency stimulation instead, it really got close to about 80% better. So about 8 out of 10 patients will enjoy their long-term pain relief and will do really well with a high frequency stimulator. Prior to the insertion of the device, the average pain scores of people who tried this a brand of spinal cord stimulation was about 7.4 out of 10. And after and carried out to 2 and 3 years, their pain scores remained very low in the mild range at about a 2 out of 10. So that really shows a dramatic reduction in their chronic pain, which obviously should be met with a dramatic improvement in their ability to enjoy their life, sleep better, stand taller, walk farther, engage in social activities, go to their grandchildren's soccer games, and cook dinner for their family. So in these patients, we know that whether you have back pain with leg pain alone, or back pain alone, you tend to do very well with this device, and overall can expect about a 65% reduction in your pain if you fall into that 80% of people. And diabetic neuropathy actually shows even better improvements. The pain scores at baseline were a little bit higher at 7.7 and were reduced even farther down to 1.7. So when we look at painful diabetic neuropathy, the outcomes in the research study were even more robust than in chronic low back pain, but also showing really amazing relief. 86% of patients were enjoying long-term relief, with 62% reporting improvement in sleep. 68% were noticing improved neurologic improvements, such as return of reflexes or sensory function, ability to feel their feet where previously they had not been able to. And overall, 92% of patients were very satisfied with their treatment. So in order to be a candidate for high frequency stimulation for painful diabetic neuropathy, you, number 1, need to have diabetes, and number 2, have been diagnosed with painful diabetic neuropathy, and then number 3, have tried at least 2 medications, and that can include anti-inflammatories, nerve pain medications, and painkillers such as Tylenol or opiates. We know that we focused a lot on chronic low back pain and leg pain, as well as diabetic neuropathy in this presentation. However, high frequency stimulation has been utilized and has been successful at treating chronic nerve pain in various areas of the body. And as you see here, there is evidence and studies to support the use of high frequency stimulation for upper limb pain, for non-diabetic painful polyneuropathy, for chronic pelvic pain and chronic post-surgical pain. We have a highlighted arrow next to chronic pelvic pain because that was actually my study that we ran from 2017 to 2018 and then had published in 2020. And overall, with chronic pelvic pain, we saw a 77% responder rate, which meant that 77% of patients received at least a 50% reduction in their chronic pain. And this is a poster presentation of that chronic pelvic pain study. And if anybody is interested, I would be happy to send you either this poster or the paper that was published in 2020. But overall, it shows that we were able to reduce chronic pelvic pain, which historically had never been shown to be successfully well treated with spinal cord stimulation in a traditional setting. And so this was very specific to high frequency stimulation. The other part that's wonderful about the team at Nevro, besides being a proprietary holder of high frequency stimulation, is that they've developed quite a wonderful family-based team at Nevro. So if you have a Nevro stimulator, you become part of their team. They hold on to your data in the Nevro cloud, which allows them and anybody that you call or get in touch with at Nevro to really understand where you are in your treatment setting. You don't have to re-explain yourself every time you call in, and it's not just a hotline. They know who you are, and you become one of their most important assets is their patients, and protecting you and having good outcomes and making sure that you enjoy the experience and that you're getting good pain relief is very important to Nevro and their team. And so not only will you have a broad frequency range, but you'll have a lot of patient support, and they will proactively reach out to you and help you maintain good outcomes with their system. So I've been using high frequency stimulation in my practice since 2015. And these are some of my patients. It's 173 patients. Each patient is represented by a horizontal line, and you see all of the blue lines are the patients who did really well with their high frequency stimulators. The gray lines are the patients who did less well. Some of them, even though they reported 40, 45%, 30% even, they're still happy that they actually got the device. It just didn't help them as much as they had wanted. Obviously, some of the patients that are at 10% probably aren't reporting great benefit, but you can see it's such a minority compared to the vast majority of patients, 92% of patients who ultimately do very well with this device. And then this is looking at long-term relief. So carrying these patients out to about 2 years. We see that some patients will drop out of their higher response rate, but that overall still a vast majority of them at 72% are continuing to experience really great relief. And of course, that's in the setting of an aging spine that's continuing to have degenerative changes, and also patients who continue to experience life and have injuries and illnesses that could create new and different chronic pain pathology. And despite that, patients have continued to have, a vast majority of them have continued to have great success with their device treating their chronic pain. Not only does it help with pain, but it also helps with some of the associated factors with pain, such as 80% patients reporting improvement in sleep, 83% reporting improvement in function, and overall, about 60% of patients are able to reduce their pain medications, and some are able to eliminate their pain medications entirely. I think that's it for the slide deck. At this time, we're going to discuss some of the frequently asked questions. So many times patients, I've given this presentation in person, and one of the first things patients ask is, do you think this will work for me? So the first thing I will say is each patient is different, and there's reasons why in their medical history, this might be or might not be the right solution for them. And so you want to speak specifically to your physician, to me, to my nurse practitioner, or if you're listening to this and you're seeing somebody else, to your other physician, ultimately to find out if you are a good candidate for this device. Another question that comes up a lot is, what are the risks of this procedure and is it safe? Overall, we know that this procedure can be done very safely and does carry low risk. There's about a 1 to 3% risk of infection, 1% in the chronic low back pain patients, and about 3% in the diabetic neuropathy patients. And so we do take some precautions to help prevent any risk for infection, such as giving you IV antibiotics at the time of the trial and implant, making sure that this is this very sterile technique, and also clarifying with you that you're not having any active infections. If you are scheduled for a trial or implant and you are developing any illness or urinary tract infection, you would want to reschedule your procedure and be infection-free at the time of the trial. Another question that people ask is it reversible? So the trial, the leads go in, and at the end of the trial, the leads come out, and it's completely reversible. And so it's always, something that you can try and see if it's for you, and if it's successful, then you can get the implant. Ultimately, when the implant goes in, we ask that you give it a good several months or a year to really see if we can adapt it to your chronic pain. And as we mentioned, most patients are able to be captured and do well with their chronic pain in the first couple of months. But ultimately, if it fails to treat your chronic pain and you are unhappy with the device, you can have it removed. It is a reversible device ultimately. Again, unlike a lumbar spinal fusion, for example, which is really very rare to have that come out. So you can try this before committing to something like a spinal fusion. And then ultimately, is it safe for MRIs is another common question. And this is compatible with MRI devices as well as security scanners at airports and concerts. You will need to let them know that you have a metallic device in your body, and you'll have a card that you can carry in your wallet. You also will have the ability to turn your device on and off at your discretion, and a control to change between various programs and settings, so that you have some dynamic variability of control of the device and the way in which you get to use it. One of the other questions that comes up is, what if I already have another device in my body? Can I get this device as well? And the answer is that it depends, and this comes down to that discussion that you would have with your provider. So we do implant this device in patients who have cardiac pacemakers, for example, even sometimes cardiac defibrillators, and patients who have other stimulators, perhaps if they have a stimulator in their back and they want to try one in their neck. All of that is possible, but it would need to be determined on a case-by-case basis. And then finally, one of the most common questions is this covered by insurance? And if not, how much does it cost? And so the answer is that it is covered by almost every insurance. Medicare has very good coverage for spinal cord stimulation. There is a list of criteria that you have to meet in order to be a candidate for this device. And that would be in the discussion with your provider to determine whether you meet all of those criteria. And then ultimately, the cost to you is going to depend on the contract that you have with your insurance carrier, which includes your deductible, meaning how much money you have to pay out of pocket before they cover certain devices, things such as co-insurance or co-pays, and then also determining where the procedure is performed. For example, having a procedure in a hospital is often more expensive to a patient than in an outpatient setting. And then finally, there is one requirement for everybody in order to get this done, and that is that you have chronic pain, and that the chronic pain while it may be causing you some suffering, depression, and anxiety, we need to make sure that that depression and anxiety is under better control or under its best control that it can be prior to undergoing an implantable device. So there is a psychological screening component that occurs prior to undergoing the trial and implant procedure, and that is a requirement to help keep you safe and get the best outcomes for you in your chronic pain. And I think that's going to be our final frequently asked question. And I hope this has been very informative for all of you, and I appreciate your time and attention. Thank you.